Great. Thanks, Alex. Thanks, Lapika. I'm really excited to kind of share some information with you and have a conversation about some things that are happening in the world. I do have some slides that are going to come up now. And, you know, I've been kind of interested in thinking about what's going on in African contexts with COVID, because it's kind of an interesting case, kind of an interesting story. So we've had kind of this, in global health, we have had this kind of idea that this is really going to be a disaster, really beginning in maybe late January, February, certainly March, April, May. There were a lot of concerns about how COVID might really expose a lot of the cracks in weak healthcare systems in African contexts, and really kind of grow without a lot of surveillance, given the inadequate capacity for surveillance and some of the laboratory testing needed to confirm COVID. There's been a lot of concern about scarcity of public health human resources like nurses and doctors and other kinds of technicians. Certainly limited financial means to address the public health needs of people living on the continent, as well as responding to economic insecurity of residents. Like, this is something we've seen a lot in the US and European countries as well, that keeping people at home also has economic consequences. We've seen, you know, lots of job loss and so on. And then add on to this the fact that like several countries have fairly porous borders, so they're not really able to control in and out flows by some kinds of means of travel. The high burdens of HIV in some countries, where, you know, we have a new disease and a like unknown way that might intersect with a population that has a large group that's immunocompromised. And then certainly a lot of the kinds of increasing aid and development work from China has made several countries on the continent kind of a high risk for introduction from China, as well as from Europe, but also kind of like people were interested in this initial kind of transmission introduction events in January and February directly from China due to some of the development that's gone on the continent. Certainly lots of residents who have high levels of economic insecurity, crowded housing conditions, lack of sanitation, all of these things were kind of in the pot, thinking about, like, for people thinking about how bad is this going to be? And then often left unstated in terms of thinking about global health and how we've kind of marshaled some of the resources that we have. Well, there's many, many cooks in the kitchen. There are a lot of organizations, a lot of agencies, a lot of just even governments, a lot of non-government organizations working in the health and development area. So coordination has been a long-standing issue for HIV, for Ebola, and so on. And so this was certainly something that people were not exactly looking forward to and thinking could have really catastrophic consequences. Well, mostly that doesn't seem to have happened. And so, at least from appearances. And so people have been writing it over the late summer. This is from a magazine, the Science magazine article, trying to figure out why we're not seeing the cases or deaths that we expected on the continent. If we look at the Johns Hopkins dashboard, this is just data from yesterday, in terms of thinking about cases, right? They're just really not there. And so there's been a lot of kind of talk about, well, what have they been doing right? What's going on? If we look at that even over time, you just see that the kind of the kind of vertical height, as well as the area kind of shaded here in terms of thinking about cases, how high they've been, how long they've been high, and so on, just really hasn't shown up. This is data to September. So what I want to kind of talk about today is what's going on. There have been some good ideas, some other kinds of shots in the dark here. And so let's look at the data and see what we find. Some of these theories are things like it's low testing, right? We don't find cases that you don't or can't look for. We know capacity is low in a lot of places. And so basically the idea here would be that the cases are there, but we're just not seeing them. That's theory number one. Theory number two, it could be bad data. The vital registration system, so the monitoring and registering of births and deaths, is generally not complete in several African countries. Lab testing capacity has been low. Surveillance systems have been limited, even though some of these got bulked up for Ebola in certain places. Overall, they're still fairly limited. They might be unreliable, and certainly we can't kind of rely on some of the data that we're looking at for deaths. So the theory here would be that the deaths are there, we're just not counting them. Theory number two, it's actually something different about the population. So you might have heard this idea that it's actually the young age structure. Young people are less likely to develop severe disease on average. Those risks start to increase among like 50, 60-year-olds and get much larger for 70, 80, and 90-year-olds. And there just aren't as many of those people at those ages in many of these countries. So like version A of this theory is that there are fewer high-risk individuals. There just aren't as many people to count as dying because they aren't there. So the cases could be there, but the deaths are lower. The second kind of version of this theory is that there are differences in transmission efficiency by age. We've been thinking about this in the context of like sending kids back to school and who should be at school, and where is transmission likely to not be taking place. How often are kids the index case to a household? These are all questions that are kind of still out there and unresolved. So I'll talk very briefly about that, but that's one of those places that's a little bit unresolved. Theory number four, well, the governments were prepared because of Ebola, et cetera, and they responded quickly. This is the, kind of statement like policies matter. I don't think many of us in the US, experiencing the US right now, would argue against that. The policies matter and government response matters. And so in these cases, the governments already had some previous experiences from Ebola, and so took those, responded quickly, understood the threat that COVID posed, and were able to kind of contain their situations. Theory number five, it's the people, right? Governments can't do anything without the people, and African communities responded quickly, with or without their governments, to protect themselves. So they adopted strategies, educated themselves or educated others, wore masks, and so on. So we're going to take a look at the data. And if you have questions, interrupt me. That's totally fine. I don't know how to see you because I'm looking at my screen, but just open your mic. I don't think there's too many of us. All right, so let's look at theory number one. It's low testing. So testing is indeed very low. What you're looking at here is data from Our World in Data of tests performed over the whole epidemic. And you'll see I've just put a couple reference countries that we've maybe think about ourselves, as well as a few European countries. And then South Africa, South Korea is in here also as a reference, Kenya, Mozambique, Nigeria. We could put in a lot of countries here. There's 54 on the continent, but several of them are coming in at well below one test for every 1,000 people. This is kind of where we were, for example, in March, let's say. So that testing scale up, even though it's been impressive from zero, hasn't really been to the same extent as we've seen in some other countries. And so just to give you an example of what that means at the population level, I have this kind of figure from Nigeria. By June 30th, only 138,462 samples, so not even necessarily people, but samples had been tested in Nigeria, which has a population of 200 million. So we're really just not likely to be catching a whole lot of cases, not necessarily of COVID, but of cases. So cases are low because tests are low. And there's a little bit more that helps us kind of think through why this is probably the case. And that's because we have a few studies now that have looked at the serological evidence. So they've taken blood samples and looked for antibodies to COVID, which suggests that somebody's been previously infected. And those numbers are, the prevalence of antibodies to COVID are substantially more than the kind of case numbers would indicate. So in Kenya, for example, 5.2% of the population is estimated to have antibodies to COVID based on some sampling around the country. In Malawi, they've measured more than 12% prevalence of antibodies to COVID among healthcare workers. So we would expect that to be high, and it's high. In Mozambique, the general population, 3 to 10% have antibodies, and this varies a little bit by location and urban versus rural. In South Africa, there's an estimate of over 20%, even though this isn't a national study. So I wouldn't hang my hat on that just yet, but that's certainly kind of an estimate that has been put out there. To tell you a little bit more about this Kenya case, so there was a study done looking at the prevalence of antibodies to COVID, and they kind of matched this up to government data. So at the time, by mid-June, the government of Kenya was reporting 2,093 cases and 71 deaths. And the study, which kind of tracked people from April 30th to June 16th, found that the prevalence was 5.2% of folks who had had antibodies. So this actually kind of puts them comparable to Spain in mid-May, which suggests that that introduction had been at a similar time and they weren't actually all that different in terms of spread. What that means is something like 1 in 20 Kenyans in the 15 to 64 age range, or actually 1.6 million people, likely had antibodies to COVID at the time in June. And the number of cases that they were reporting, again, was 2,093. So we've kind of thought a lot about what we're missing in terms of cases. And people have put out there, well, we're only catching 1 out of 4 cases, or we're missing 3 out of 4 cases, or we're missing 9 out of 10 cases, maybe 19 out of 20 cases at the very beginning or in certain contexts. What this means for Kenya is that actually they're only catching about 1 in 750 cases, if all of these estimates are close to reality. So in mid-June, the expected number of cases would have been closer to 80,000 if they were just even catching 1 out of 20 of them. So we can kind of see here that difference in terms of what testing is actually, what that low testing is actually causing in terms of who's missing. So theory number 1, it's low testing. The cases are there, we're just not seeing them. That's definitely happening. So let's talk about theory number 2. It's bad data. The deaths are there, we're just not counting them. At this point, this is an image you might have seen is from the New York Times website, looking at excess deaths. And excess deaths is a way that we try to figure out who's died from, in our case now, COVID, in a context where we didn't originally have good information on that. Or that information comes in different ways, isn't always kind of tabulated the same way. In some cases was early on kind of categorized as a pneumonia death, or maybe has some other kind of comorbid factor that was actually recorded as the cause of death. This is the way that we get kind of around all of that. We just look at deaths from all causes and how it compares to what we would expect based on the seasonal variation in deaths from the most recent previous years, right? And so this New York Times graphic is showing you in the kinds of little blue C's how deaths would likely go in a normal year in Peru, in Bolivia, in Mexico, Mumbai, India, Chile, Colombia, etc. And right now, we're maybe all like now getting very familiar with that peak that happens anywhere from January to June, depending on where you are, but is there all the same, right? So this little shark fin sticking out everywhere is what we're kind of attributing to COVID. Now, notably, this isn't just people who died of COVID. This is people who died from possibly other causes that are more likely to die, given the different kinds of stressors that COVID has put on the healthcare system, for example. So if you had a heart attack and you were going in an ambulance to an ER that was already overcrowded from COVID cases, you might not get the same rapidity of care or level of acute care, and so you might be more likely to die. Some other work that I did showed you we're more likely to have died from a gunshot wound during this period because of some of those stresses on the healthcare system. So that is one note. This isn't only people who died from COVID in particular, right? It includes collateral damage to other areas. So what does that look like for some of these African contexts? You'll note that none of these countries, as far as I remember, are African countries, right? Because there actually isn't a lot of good data. This is kind of like one of the big problems. So estimating excess deaths is hard a lot of places, but it's particularly hard in African contexts because the data before the pandemic weren't great. So vital registration data have been bad lots of places and been especially bad in several African countries. You'll see here they're kind of indicated in red, where the kind of index score that a group that's monitoring the vital registration data systems has kind of created this index, and they're kind of performing poorly on it. And researchers have kind of been tracking this and suggest that very little progress has been made in terms of improving these systems since the early 2000s. So we haven't seen a lot of improvement here. The data before, like the baseline data, are kind of bad. And it also probably means that those COVID deaths aren't being registered. So we're just not seeing them in those data. When they do show up, it's even a little bit harder because in several of these countries, the baseline patterns of death, so what people die from and how much they die from it, are actually a bit different. So compared to, say, like the US, for example, several African countries have a higher share of deaths from non-disease causes, like road accidents, for example, by a few percentage points. And so what happens when you try to estimate these excess deaths is that you actually get a negative number, that COVID, the pressures of COVID, the public health measures, the lockdowns have actually saved people's lives more than COVID has taken them. So that's what you're seeing here in this circle, is that when we look for the excess deaths, when a country like South Africa was in lockdown in this late March through May period, the deaths from other causes were substantially reduced enough that even though they were counting COVID deaths, that the math wasn't working out, right? On net, there were actually fewer deaths overall. And so it becomes hard to kind of see what that effect is. And so the people that have been working on this and, you know, creative problem solving here kind of take a different tack, which is to say we're not gonna try and count these ones where they're below the expected line. We're only gonna kind of project out after we start increasing and get close to that line of what the baseline was. And when they do this, we can match up some of those dates and show that on July 28th, the government of South Africa was reporting about 2,400 deaths. And the excess deaths at that time, just from May to July, were estimated at 28,000. And I've updated that, not the figure, but the data below to November, where on November 3rd, the government was reporting 19,539 deaths, and the estimated excess deaths from all causes. So again, not necessarily COVID, but COVID related, those indirect things are added on as well, is almost 50,000. So you can see here the kind of gross miscounting or undercounting of deaths. in these contexts as well. So it's not just that we're undercounting cases, we're definitely undercounting deaths in these contexts. Somebody have a question? Okay. You might ask, well, governments aren't reporting overloads at hospitals, right? This is something I've read at least a few times thinking about Kenya. Kenyan government is supposed to have a lot of cases, but isn't reporting overloaded hospitals. So what's going on? I would caution people kind of paying attention to this, this indicator, just because people don't tend to have very good access to hospitals in many countries on the continent. So what you're looking at here is from the WHO's report on healthcare resources and some health behaviors, and they've measured the density of hospitals, so how many hospitals per 100,000 population across several countries. And the red here is that there's less than one hospital per 100,000 population. So is the orange, in fact. All of these are less than one hospital per one, sorry, not all of them. Red and orange are less than one hospital per 100,000 population. And these metrics are worse in rural areas. So you can imagine people aren't going to the hospital for this quite a lot because geographically they're just not there. You can also look at how out-of-pocket expenditures might preclude people from going to the hospital or persuade them not to. In most of Western and Eastern African countries, the out-of-pocket costs for healthcare are 80% on the user for private healthcare. And for Central African countries, that's 30 to 80%. So these might be very cost prohibitive going to the hospital for these cases. Additionally, one more study, sorry, thinking about who's actually dying in the hospital. So let's say you actually get to the hospital, you're more likely to die than in other places. So one study looking at in-hospital mortality in 6 different countries in 38 hospitals found that if you'd been admitted to critical care, your likelihood of dying within 30 days was pretty much 50-50. And this is quite a bit higher than the global mortality due to COVID following critical care, and was resulting in between 18 and 29 additional deaths per 100 African patients. So, you know, something like additionally, you know, 1 in 5 patients, 1 in 3 patients dying due to COVID, mostly because of lack of critical care resources. So some other estimates that the authors of this study do look at differences in patient characteristics. They find that those aren't widely different. Differences in staffing, these aren't widely different, but rather it's the difference in critical care resources that are causing this discrepancy in deaths, this higher mortality in hospitals or 30 days following hospital admission into critical care. Just to give you another reference point, in Milan, Italy, the 30-day mortality following hospitalization during the first wave, so that March, April wave, that was terrible, was 19.7%, according to another paper. So it's bad data. The deaths are there. We're just not counting them. That's definitely happening. Okay, let's look at theory number 3. It's the young age structure that's keeping cases low. Essentially, there are fewer high-risk individuals. The cases might be there, but the deaths are lower, right? So we know age is a risk factor for severe disease, okay? And the median age in across most of the continent is 20 years or less. So we have several countries where, a handful of countries where 14 is the median age. That means 50% of the population is below age 14. You know, several where it's 16, several 17, 18, 19. That means that you have a very young population, and we know that age is, you know, protective at younger ages for COVID. So we can think that there might be something to this, right? Only 3% of the population in sub-Saharan Africa is over age 65. So those, there just aren't a lot of those folks who might be in that highest risk of severe disease and potentially death category. And there certainly aren't a lot more folks in the 70s, 80s, or 90s either. So one way we can kind of think about what that might mean is look at the population distribution tables. So this is like a true demography thing. So we're looking at the, where's my mouse? We're looking at the share of the population in thousands here by age bracket. So age 0 to 9, 10 to 19, all the way up to age 90 plus, and then by gender, right? So some societies get a little imbalanced as they age or have big events like wars happen where one gender is more affected than the other, and your table here gets a little lopsided and screwy, right? So each of the blue things is the population age structure of a country. And what you'll notice is you've got some Western countries up here plus Korea, and then you've got handful of African countries down here on the bottom. And there's actually a lot more to this figure that I've cut out of the middle, but that we can go back to and look at if you want to. But just to give you an idea of some countries that you might be more familiar with in terms of Kenya, South Africa, and so on. The deaths largely look the same here, right? The pattern here is the same. What's changing is the axis based on how many people are in these categories, right? So it matters how many people are over 90, and that will, tell us what the share over here is, which is the expected deaths in thousands, right? And what you notice here is that European and Republic of Korea have this kind of bulge out. They have more people in these older ages, more people in their middle ages, and thus more people who are at risk of severe disease and death. If you go to these towers here for Kenya, South Africa, Mauritania, Senegal, Cote d'Ivoire, what you notice is there's not very many people here. There's even fewer people in this 80 to 89 range, right? And this is where the majority of the deaths are going to occur, but there just aren't a lot of people here. So this number is quite small. And so this is like, affecting the kind of likelihood of seeing a lot of deaths is that there aren't a lot of people in the age ranges where we would expect deaths. And the estimated deaths that we saw in the previous theory by age structure are actually pretty consistent. So those excess death estimates and these estimates of where we would likely see these deaths and what scale they should be on in terms of thousands are actually pretty consistent where we have some of those estimates. We were estimating that mortality was approaching 50,000 for South Africa, and that's about where this is heading in terms of having the numbers of people that they have in these age categories by just their population age structure. So certainly from the previous theory, we could say deaths are occurring at levels higher than are being observed in some of the data that's being kind of published. But these estimates by age structure are pretty consistent with our estimates of excess deaths. And they are both lower than the recorded deaths. They're also lower than many countries with older populations. So this age structure might be keeping deaths lower, essentially. I don't have a lot of, I don't have a solid take on evidence of transmission efficiency, just because I think that information is still evolving, that likelihood that younger children will transmit to other people in their household or to other children and so on. That's evolving, and we kind of seem to have a lot of conflicting studies out, week after week. And so far, I think this transmission efficiency piece is not looking like the smoking gun was predicted to be here. That is to say that it's not that protective factor that we're thinking about, but really this piece of there just are fewer people in the highest risk categories by age. And so we're seeing fewer deaths overall. So we'll check that off as theory 3. It's the young age structure, probably. And for sure, there are fewer higher risk individuals. So the cases could be there and the deaths could be lower, and that those could be consistent. And we'll put a question mark on this differences in transmission efficiency by age. That's, I think, still evolving, but likely to not be, the reason things are different for African countries. So let's look now at governments, what they've been up to, how they're responding, and then we'll look quickly at how African communities are responding. So theory 4, the governments were prepared, they acted quickly, they have plans and they're executing them, and they're doing that sooner, and so they're containing things better. Certainly, African governments have taken several public health and social and economic measures in response to COVID. It's not clear that these were substantially earlier than in other countries on average, at least not to me. So if we think about some of the timelines, they're actually, I think, very consistent with things in the US and in Europe, for example, in terms of beginning with surveillance at airports, beginning with CDC monitoring, in January, importing cases beginning in February and acknowledging that they've detected those cases. I think some of the things that are different here is that the African Union adopted a continent-wide strategy in mid to late February, which may be important just for thinking about coordination and mobilization. By March, by the end of the first week of March, 9 countries had more than 40 cases. And so in a lot of ways that looks very similar to the introduction in several US states, for example. Some other things that they did is increase their lab capacity. And they did really focus on scaling up testing. You saw already that it's still pretty low, but it was even lower in March. And so they increased the laboratory capacity from 2 labs on the continent that could detect and diagnose COVID to 43 functioning labs by mid-March, and that's an astounding feat. Several countries closed their borders to foreign nationals and have now kind of modified those criteria to make sure that you've had a negative test within the last 72 hours, for example, or that you quarantine on arrival. Several countries also implemented national or localized lockdowns, especially beginning in the 3rd and 4th weeks of March, continuing into April. This is highly consistent with what several US states were doing in terms of timing. We'll see in a second that they look a little bit different in terms of enforcement, but in terms of timing, it's not clear to me that this was a lot earlier. So with 54 countries on the continent, it's easy to cherry pick slightly earlier actors and kind of forget about everyone else that's kind of pulling up the rear, essentially. And so I'm not convinced that this was an earlier thing. What I do think it was that was different was the kind of coordination of national level decision making. There was certainly an early continent-wide leadership, mobilization, and organization. Several countries kind of consolidated executive power to direct action in across many contexts. And when you have one decider, things move more quickly. There's pretty consistent messaging from many of these governments. So we don't have the problem there that we have here in the US with very inconsistent messaging around, for example, what to do, what not to do, when to do it, and so on. And it hasn't been politicized in the same way, which is certainly important. Several countries also implemented their social welfare packages quite quickly. That's not to say that they were perfect or couldn't be expanded, but they got them done in April as opposed to, for example, the US, which didn't get this done until, say, June. And then the other key piece, though, is the enforcement of that response. So police and security forces have had the ability to enforce lockdowns with arrests in several places. So some of the kinds of figures coming out in mid-July were that police in Zimbabwe had arrested more than 105,000 people since March. for violating COVID-19 regulations. There are also media reports and human rights reports on police violence against citizens and journalists in Nigeria, Kenya, Zambia, Uganda, and Namibia. So I think there is certainly a difference in levels of enforcement, with arrests and detention being a kind of primary stick that's been used against people. And in at least a few cases, leaders have used COVID as a cover to consolidate power, to hoard financial and other social resources, and to enact violence against already marginalized groups. So it's not been a, it's not been a rosy kind of outcome everywhere, that is to say. So theory 4, I would revise just a little bit. Governments were somewhat prepared because of Ebola, certainly more so in Western African contexts, and they were able to consolidate decision-making and messaging at the national level, and they enforced public health measures with police force. Theory number 5, African communities responded quickly despite governments, so with or without their governments, to protect themselves. Let's take a look. So some of the best data that we have on this is mobility data. We've been looking at this in the US and in other countries for a while now. This is data based on phones and where they are. So you may be in somebody's data set. And so if we're thinking about Botswana, this is what the mobility curve looked like for people spending time at home. And so the 0 line is the baseline, which for most of these data is like the second week in February or something like this, right? So how people are doing just before the pandemic. And what you see is that residential mobility increased during the lockdown that Botswana implemented. This was a national lockdown. The first one was 48 days. And so you see this spike. This is all the people staying home. And the kind of time at home kind of starts decreasing as lockdown goes on. People get, more and more involved in back in their lives, and certainly goes down again when that lockdown is lifted. Before the lockdown, people had already changed their mobility by about 10%. So they'd increased their time at home by about 10% before that lockdown. So they're kind of anticipating some of those things or acting early. And then another thing to note is after they did a second short lockdown just in Gaborone, in the capital, you note that, where's my mouse? This line hasn't returned to 0. So some people are still staying home despite both of these lockdowns having been lifted in October, right? So it hasn't returned to baseline. People are still spending time at home. What does this look like in a country that didn't enact a national lockdown? So let's look at Cote d'Ivoire. What you're looking at is a couple different kinds of mobility. So that residential mobility that we were just talking about is this orangish line, yellow line up here at the top. So, people are staying home beginning in about April, the end of March, more than they were, right? This kind of goes down a little bit more shallowly than like lockdown on or off, and kind of like stays, just about like between 0 and 10%. So it's certainly above the baseline, not a lot above the baseline, but kind of hangs out there, and was highest in April and May, but goes down. There's no other lockdown. And other kinds of mobility decreased. So these red and blue lines here are blue is retail and recreation, and red is transit. So this is people kind of in transit spaces or in retail spaces that, the phone GPS acknowledges as these kinds of spaces. And so those go down pretty rapidly at the same time that people are staying home, but have largely returned to normal or above normal by July, essentially. So it's not like clear in all contexts that people have are continuing to stay home, for example. And compared to the rest of the world that we have data for, like this, which is 36 countries, the median sub-Saharan African country, which comes from about 8 countries, has returned to baseline or more mobility in retail and transit. So that is to say that by now, the countries that we have data for are mostly looking like they are at least back to baseline, if not kind of doing more following some of these kind of stay-at-home times. So are we overhyping lockdowns? Probably. In the largest cities, at least 60% of people live in slums or townships in close quarters with limited access to water and sanitation. That is to say, even if they were legally required to socially distance, they couldn't actually do it. And despite some social welfare measures, in some countries, lockdowns have really disrupted supply chains for basic goods and had a lot of transportation disruption problems. And these have doubled the cost of both foods and transportation, which has really made life very difficult in a lot of places that were already somewhat food insecure. Also, we've seen reports of a large amount of non-compliance among people who rely on being in markets or selling things on the side of the road, day laborers, craft workers, who really just have no financial security to be able to stay at home. And then finally, masks haven't been politicized in the US, that's a plus, but are still impractical for all day use in social settings or multifamily households, for example. So we've seen some kind of pushback on that as well. Okay, last one. Sorry, I got ahead of myself, that piece there. In terms of, oh no, I didn't. Theory 5, we're just gonna revise it again and think about how African communities responded quickly despite governments to protect themselves. That does seem to be true where they were able to do so, and with the big asterisks that substantial gaps remain for many in terms of being able to comply and not having this cost them on the back end in terms of food insecurity, poverty, reduced mobility, and so on. Okay, we did it. I see that there's some stuff in the chat. Thank you very much.